afternoon. Fish with my good buddies retiring for a big meeting for 2 days. I'll be available. The other ones are 8. The 12 ones go to 18. This is like the world, the plane's crashing. So it is. Don't even bother with it. Oh yeah, that's sorry. I'm around slave to think about whatever. A little slow, but I'm getting there. So, yeah. Okay, now. Are we okay in the back? Good? Good. Over here in the wing, guys? Yeah? Okay? Okay over there? Yes? Sound okay? Somebody wrote me that the course capture mic is clear and the classroom speakers are not. Is that true? Well, what do you want louder? Mine? I don't think I can go any louder. That's the overall mic. That's it. How about this? Is that louder? Okay. Thank you. Okie doke. All right, a couple things, a little housekeeping. So in terms of this course capture, I thought about it, and I talked to some of the students there's a couple students who actually have to use course capture because they can't make it to class for issues. So it wouldn't be fair to kind of stop it for them. So I'm just going to continue course capture. And since they're at home, doing this, I also cannot really do anything that says this is important for the exam period, because they would be, at a disadvantage. I'm just going to continue as we've been going through the class, and not worry about the attendance issue, which I talk to other faculty. Turns out every time you do course capture, half the people don't come to class. Interesting. Luckily, if you're in med school and if you miss rounds, you're in trouble. So I'm used to people actually being involved in the Socratic method, but I guess this is a little bit different. Okay, so that's fine. In terms, we have a lot of issues related to proctoring, which I think they're all resolved literally as of this morning. So everybody will be getting an email sometime during the day as to where to go, etc. The brunt of the people are right here in this room. But you'll get that out today, and it got resolved. All right, so did anybody in this class, was anybody a Cub Scout? Any Cub Scouts? Did you do Pinewood Derby? You did? Really? What is Pinewood Derby? You made a little race car? You did? Yeah, so I had the high point of my week, maybe the month. My grandson was in the Pinewood Derby on Saturday for his Cub Scout group. There he is. There's his car. He's a happy dude. He actually won his division with the blue stripe. With the blue thing was for the bear. Cub Scouts have 5 divisions. He was a bear, and then he won for all divisions. So he's a happy little dude.
He's in Texas.
Because that's his baseball team. He just got put on the Texas Rangers in Little League. He had to get his Little League picture taken. So he couldn't, to get to the race, he had to go right from the picture place with his mom to the Cub Scout event. He didn't have a chance to change. He and a few other guys were in their baseball uniforms. So it's very exciting, for me at least. All right, so let's get back to basics here and finish up memory. We'll see where we're at. Again, the exam stops on last Wednesday, the stuff, and maybe we'll have a little break today and we can go over if there's any follow-up questions. So I want to go, we talked about transient global amnesia, where you have a TIA, a transient ischemic attack, in the vertebral basilar distribution that perfuses your hippocampi, right? We talked about that. We talked about some of the causes. We talked that it's not so benign. It's a very interesting syndrome when you see a patient. And we're just going to go through all the things that you could see that produce relatively subacute to acute onset of memory loss. Obviously, a stroke is the most acute. If you get someone who comes in, this is a 20-year-old undergraduate. Let me get the lights a little adjusted. Sorry. Who came into the emergency room. She was in a community college. And she came into an emergency room with fever, confusion, and a headache. Fever, confusion, and a headache. There's a large number of things that can do that, ranging from the most common, which would be a bacterial meningitis, to maybe a little less common, maybe a viral a viral meningitis. You can have other rarer infectious disease causes. We had a clinical conference 2 weeks ago at Alta Bates, and we actually had a lady who came in with fever, confusion, and a headache. She was on immunosuppression for rheumatoid arthritis, and my doctor colleague, she basically died in 2 days. She had amoebic encephalitis, which is extremely rare. So there's lots of things that can do this, but the one that is you really don't want to miss is herpes simplex encephalitis. And herpes simplex encephalitis, it's herpes simplex virus type 1. Type 1 is what you get for fever sores, which I get and about 10% of the population get. Mine break out if I'm fly fishing and I'm up on a lake and I don't have lip protection, right? In fact, they check for herpes drugs with people who are skiing. It's the same virus, but don't worry. If you have herpes simplex type 1, you're not liable to get herpes simplex type 1 in your brain. Okay, but it is a herpes simplex type 1 virus. And by the way, in this room, 50% of everybody in this room, if you look at their fifth nerve ganglion, your sensory ganglion to your face, 50% of us have herpes sitting there. And in a few people, it activates. Some, it goes to the lip, and mercifully, in a very small percentage of the people, it goes central into the brain. And when it does that, and this is what you don't want to have happen, it produces a hemorrhagic encephalitis in the temporal lobes. It chews up the temporal lobes, and if it's not treated, it has an 85% mortality. Now, this lady came in with fever, confusion, 20 years old, and if you look at her contrast MRI scan, it's really quite amazing about this virus. It's neurotropic for your limbic system, which we'll be talking about later in the course. Your limbic system, the part of your brain system that controls your emotional behavior, social emotional regulation. Just like polio virus gets your anterior horn cells, producing paralysis, and the 1916-17 pandemic, the virus liked to go to the substantia nigra with residual of Parkinson's disease. This is another neurotropic virus, herpes, and you can see it gets your medial temporal lobe, enhancement, hippocampus, amygdala, orbital frontal cortex, and cingulate cortex. And all of these, if you think about it, they're all connected. And basically, that's the presentation. The treatment is the same treatment you'd use for herpes simplex on your lips, but instead of being a topical or a pill, you put very high-dose intravenous treatment. And this person resolved actually completely because we caught her quickly. If we hadn't, she would have died. And what happens is, why do you die? Well, you don't die from hippocampal lesions. What happens is the virus actually, there's amygdalo-hypothalamic connections, and I showed virus here. So the virus goes up into the hypothalamic region, and as soon as that happens, the game's over, because that's the part of your body that controls pretty much all your homeostasis, right? Your endocrine, you pick your poison. And when you get stuff in there, the patient becomes completely uncontrollable in terms of their metabolic parameters. And you can see, again, the virus features hemorrhages. See, that little red stuff is hemorrhages in the brain. So be careful if you're ever in the emergency room. Don't send them home. Because if they survive, you can end up with this. This is chronic herpes simplex encephalitis. This obviously is a post-mortem case. You can see the temporal lobes are chewed up. And you can, by the way, the mammillary bodies in this particular scenario are spared, right? But the hippocampus is chewed up, as is the cingulate cortex. It's really tracked along that pathway, right? Really very neurotropic. This is an unfortunate case of a mother in Berkeley who had fever and confusion, and she bounced in and out of a couple emergency rooms, and she was pregnant. Probably she was a doctor's spouse, and I think you never know in terms of how people get treated. In any event, she ended up, when she finally got diagnosed, she'd already had very advanced chewing up of her temporal lobes. This is actually her scan. You can see this temporal lobe is gone. Maybe the superior temporal gyrus is intact, and the medial temporal lobe on this side is gone. And she was left with, again, a profound anterograde memory problem, which means she can't learn new information. So you got to get on these cases right away. Now let's switch. We've talked a lot. We've talked about entorhinal cortex and disconnection in Alzheimer's disease. We've talked about strokes in the hippocampus, acute onset of memory loss. We've talked about viral encephalitis, herpes. Let's now go to the mammillary bodies here. And someone might say, well, why didn't the mammillary body get affected in herpes? Why didn't it just go there? I don't know. Maybe it's hard to track along the entire length of the fornix. I really don't know. But now we're going to focus on the mammillary bodies, because if you just knock out that structure, just the mammillary body, you look just as bad as if you had herpes simplex encephalitis. You look just as bad as if you had a bad cardiac arrest and burned out your CA1 cells from excess glutamate release, which we've discussed. And this is another syndrome that's quite common, and this is a nutritional syndrome. Right, so now we've got stroke, hypoxia, infection. Now we're going to talk about a nutritional syndrome, and this is thiamine deficiency. And if you run out of thiamine, if you stop taking in thiamine, within 6 weeks, you're basically depleted of your body thiamine. Now, some of your vitamins take forever to deplete. So your B12 will take you 2 to 3 years to deplete, but thiamine is 6 weeks. And once you lose your thiamine, you get a syndrome called Wernicke-Korsakoff encephalitis. Okay? Wernicke-Korsakoff encephalitis is hemorrhagic lesions in the mammillary body and in the brainstem and in the thalamus. And you need to diagnose this one quickly, because if you don't, you're going to end up with a patient who has residual, severe, profound anterograde memory problem. And just to set the kind of stage for this, many years ago, probably 15, when I was at Highland Hospital, I had a young woman, Berkeley undergrad, who had hyperemesis gravidarum. Does people know what that is? Hyperemesis gravidarum? Some of you may experience it later in life. It's bad morning sickness, right? About a third of women get it in the first 3 months of pregnancy. In fact, Kate Middleton, I think, had to be hospitalized to get hydrated for it. And this particular undergrad had it, and she was trying to kind of not tell anybody she was pregnant, and she went on a liquid diet because she was so nauseous, and she developed a Wernicke-Korsakoff encephalitis. It presented to the emergency room, and how did she present? How did this patient present? But they present with acute onset of amnesia and confusion and confabulation. I saw a guy Thursday at the VA in Martinez, and he was a residual from a Wernicke-Korsakoff encephalitis. He hadn't been treated probably early enough, and he was left with profound anterograde amnesia and confabulation. So when I saw this gentleman for the first time, I said, "Mr. Blank, what did we talk about last week?" Now, I never saw him before, right? And he started to tell me what they talked about, right? So he's confabulating, and he's profoundly amnestic. He couldn't learn any new information, and you know about that from our exam. There's often ophthalmoplegia, which means the eye movements are not yoked, right? Your eye movements should always be yoked. They go together, right? What happens is they don't get yoked. You get double vision, you get various eye movement abnormalities. If you get them quickly and give massive intravenous thiamine, I like to also give magnesium, because magnesium is a cofactor for thiamine transketolase. If you do that, you can often completely reverse it, but even in the ones that you don't reverse, the memory problems, the eye movement problems, and the gait problems will typically correct, but the amnesia may persist. It's a B1 deficiency. 6 weeks is all you need. It occurs in alcoholics and poor nutrition. It's a very common cause, but be careful. Be very careful. Remember, I told you the case of the hyperemesis gravidarum. That's not an alcoholic. There are many other causes of severe nutritional problems that you need to keep, in your mind. And I will refer back to the original monograph, by Wernicke and Korsakoff, and there were 3 cases reported in the original monograph. 2 were nutritional depletion from chronic alcoholism. The third one was actually a young woman who tried to commit suicide with lye ingestion, right? And she burned her esophagus and could only hold down fluids, and she got a Wernicke-Korsakoff. So even in the first reported case, the first cases, it was not just what's going on back there? Is this funny? No? I lost something. No? Okay. I didn't know. People were laughing. Anyway, it's not a nice scenario. Anyway, occurs in alcoholics, but it can occur in any case. Can be corrected in the emergency room. If not, you have permanent problems. And the problems are usually due to damage to the mammillary bodies for memory problems and to the dorsal medial nucleus, to the thalamus. And interestingly, and we'll talk about this when we get into frontal lobe function, across all species, if I want to say, where is your lateral frontal lobe, the part that you're all using here to kind of think and plan and extract information, if you put a tracer in the dorsal medial nucleus, wherever that projects, it could be a pigeon, a mouse, a rat, a dolphin, a gorilla, a human, that defines your frontal lobe. So you got a double whammy. In these patients, you have their memory system impaired and their executive system impaired. Okay, so here is the acute syndrome, what it looks like. This is a swollen mammillary body. See those little red dots? Those are what are called petechial hemorrhages, little small bleeds in the brain. This is swollen. And then this is the end case where you treated the patient, but it was too late to save the mammillary bodies. And you'll just have to trust me, these are really shrunken, little teeny mammillary bodies. And then you have a chronic Korsakoff's, which they call a confabulatory psychosis. The patients are not psychotic. They confabulate, but there is no element of psychosis in these patients at all. And a shrunken mammillary body, and that's what you want to avoid. So here's a patient with this syndrome, and one thing about him, you say, when you look at a report, let's say you're a clinical psychologist or you're MD, whatever, there's a little code word that you see when the person's being described. And that code word is, looks older than his stated age, right? That looks older than his stated age usually means they've had a pretty hard trip through life, basically. Could be many different causes. So let's just take a look at a patient he's come in, we've treated him, but he had residual, we didn't get him soon enough, and he has residual confabulation. Okay, here we go again in our lovely, that sound system is up. Okay, guys, let's play this game again here. What? Well, I don't want output device. This is the worst AV setup on the planet Earth. Okay, so what do you think? We got the computer. We got the volume controls. It's not muted. We got a double attempt at... Do you remember what happened that brought you into the hospital?
I live right around the corner from the bar. Mm-hmm. So I left my car in the
he's
parking
58
lot.
years old. He doesn't look like, he looks much older.
Street. Some guy hit me.
Okay. So you think you were hit by a car? Do you remember getting hit by the car?
Not really.
No. Everything he tells us is made up. It's all confabulation.
If I tap twice, you tap once. And if I tap once, you tap twice. What's the rule? Why don't you tell me the rule?
If you tap once, I tap twice. If you tap twice, I tap once.
Okay, perfect. Let's see if you can do it, okay? Give it a try. Ready? Go.
I'm teaching him a little delayed task. He has to switch the rule and it's a frontal lobe task. He can't do it.
If you tap once, I tap.
He knows the rule.
Twice.
He can't implement it.
Tap twice, I tap once.
Okay, let's try it again. You ready? Here we go. Okay, so he's not able to do the alternation behavior. All right, I'm going to tell you a couple things I'd like you to hang on to.
I'm going to check his anterograde memory at the bedside.
Baseball.
Tree.
Tree.
Window.
Window.
Say them back to me again.
3 things.
Baseball, tree, window.
I'm going to ask you a few minutes, so I want you to pay attention to them, okay?
That's his copy. It's not. I've seen far worse.
This is the memory task for Ray Osterek.
However, it took him 11 minutes, and the average is about 2.5 minutes.
They have to copy this complex shape, which he could do. That was his copy.
So it's
now you
a
have
spatial
recall.
problem also. I asked you to remember some
his
words.
spatial recall. I don't know what happened there.
Tap.
Oh, it's not in the corner. There's nothing. You can't see it. But his spatial recall is 0.
A spatial problem also. I asked you to remember some words. Do you remember any words?
Cat. Tree.
Good.
Got 1. 3 recalls is 1 out of 3.
Okay, let's back up. The first one is not correct, but I did ask you to remember a sport. What sport was that?
I'm cueing him.
Yeah,
3 recall.
Pitcher.
Not a pitcher, a sport. What sport did I ask you to remember?
He was in the right semantic field.
So I'm trying to do
pitcher.
Cue recall with him. What sport? His free recall is 1 out of 3. He remembered tree. What sport?
Football?
No, I'll give you a choice, okay? Hockey, baseball, or basketball?
Baseball.
First choice. Okay. Very typical. This is the typical pattern you see in the true amnestic. If you have someone who remembers absolutely nothing, 0 at 5 minutes, 0, and they get nothing with priming, with cueing, they get nothing with forced choice, you're a little concerned it's not a real amnestic patient. This guy's profoundly amnestic, there's stuff rattling around in his brain, right? He got 1 out of 3, and then he got 2 out of 3 with cueing, and so on. That's the typical scenario. This is what you want to avoid. So his mammillary bodies would look like this. They're shrunken and severely damaged, and we don't want to have that happen. I've seen people, well, there's all kinds of causes of this. Remember, it's nutritional, basically. So then if you have a confabulator like this man, whatever he was telling me, he's in the hospital because he was hit by a car, it was just all made up, right? He's confabulating. If you have a pure amnestic, pure, as in a CA1 hypoxic or a hippocampal infarction, right? Just damage limited to the hippocampal encoding system, you have severe anterograde memory problems, but they don't confabulate. If the patient confabulates and makes up stuff, they must have memory plus prefrontal cortex, right? And this is just some examples of people with aneurysm ruptures. You don't need to get into the details. You just need to kind of remember the confabulators. In the Wernicke-Korsakoff, they're confabulating because the dorsal medial nucleus of the thalamus is involved, which is making their frontal lobe not work. The network is not working properly. Okay, so back to the PAPS circuit, and we've gone through nicely through hippocampus, mammillary bodies, and now let's go up to the anterior nucleus of the thalamus. I will just throw in here, for those of you who think this is, who cares about knowing about the neuroanatomy of amnesia, in the 80s, a group in Japan developed a new procedure for taking out pinealomas, which are pineal gland tumors in children. And their approach to get at the pineal gland was to cut the fornix. They obviously had not learned properly the memory encoding network. The kids had their tumors successfully removed, and these are kids. They were all left with profound anterograde memory loss because you cut the encoding circuit. So the fornix is rarely damaged by itself, except in this one particular. I don't think I've ever seen a selective fornix damage ever. But it can't just, there was a surgical misadventure that produced problems. So as you go up from the mammillary bodies, you shoot up into the thalamic regions, and there's a little tract called the tract of Vic de Jour, D''A''Z''U''R', comes up into the thalamus. Here's a patient with a brain tumor, a glioma, which we've talked about. We talked a lot about them growing in the cortex, but you can get them growing in the brainstem, as in kids, but in adults you can get them growing in the thalamus. Here's another patient who's had a thalamic stroke, and you can see that this is a CT scan. You can see the low-density lesion there. And both of these patients would also they would look like somewhat mammillary body damage, right? So it's really this circuit. And anywhere you ping that circuit, and different diseases ping it differently or in different places, you get memory problems. So it's a very important finding in the emergency room. Now, a couple last things about a little bit more sophisticated, not sophisticated. Another thing to think about is your spatial memory system. And we talked about this. We said you could point to the, right, we did, people know where they came in, they know where they are coming around campus. You have a precision spatial map, and in fact the Nobel Prize in medicine, I think it was 2014, was actually awarded to the Mosers for doing rodent research on the spatial memory system. And they focused on this area right next to the hippocampus, the entorhinal cortex and the perirhinal cortex. In fact, most of their recording was in entorhinal cortex, which led to them getting the Nobel Prize for laying out the fact that you have a grid, you have an organization of your cells that reflects a grid of space. So you have some cells that give you a grid of this room. You have another distribution of cells that give you a grid layout of the campus. So really important stuff. You have place cells that fire only when you're in a certain place in the room. So if I had an electrode in your parahippocampal region and you walked around the room, there'd be just one spot where those cells would fire. Place cells, grid cells. And we can actually study that in humans because very selective lesions, and I forgot to load up the movie, very selective lesions in this area of the brain can produce a severe problem in spatial memory. You don't know where you've been, you don't know where you're going to, you just can't organize any spatial coordinates. And this is a nice study done with fMRI scan, actually from a group, Mark Desposito's group. And basically, you're in the scanner, and you start here, and you have to get to different targets, right? And when you get to this target, you get a reward, and then you get to this target, etc. So you've really got to do a lot of exploring, basically, in the scanner and look for these targets. And as you do that, you begin just like a rodent in a maze. You end up getting a layout, a spatial layout of this grid that you're going through. And when you check, these studies were done when Mark was back at Penn, and these were actually, I think they were mostly med students, but I don't remember. It doesn't really matter. And they had to do the task, and then, did they really understand the map? Did they just randomly find these things by trying to go here, go there, and get the rewards, or did they really understand the map? So this is actually what they had them do. They had the subjects, after they'd done the experiment, in the fMRI scanner, they basically asked them to draw what they thought was the map that they were navigating through, right? Because they would only see it one move at a time. They didn't see the whole map, and they were quite accurate, really. So they knew where it was. And lo and behold, what you find is you get these selective activations right here. This is fMRI activations in the parahippocampal cortex. Para means next to. It's cortex right next to the hippocampal formation. And as a nice clinical convergent piece of information, if you have selective strokes in this area of the brain, you develop problems with spatial memory. You actually can't learn anything new. You would know a prior map that you've learned, but you could not acquire a new map of space. So if you just arrived on this campus as a new student, and God forbid you had parahippocampal damage, you'd have to have people take you to wherever you had to go each day, because you'd never be able to really develop and lay out a spatial map of the brain. Okay, so we really focused a lot on long-term memory and really declarative memory. Episodes, facts, knowledge, semantic space. By the way, I think you saw the gentleman with the Wernicke-Korsakoff on the movie. I think when I asked them, cued him again that it was a sport to remember he said pitcher. So he was floating around in the right semantic field. He just didn't pull out the right one, which was baseball. Very interesting behaviors. So that's what we've been talking about. But there's another form of memory that's very important, which is procedural memory or implicit memory. So the stuff we've been talking about is often referred to, is referred to as explicit knowledge, facts, etc., the kind of things you're kind of absorbing to get in preparation for whatever you're doing with this material. But there's also procedural memory, which is skills, priming, and conditioning. What would be a typical example of a procedural memory skill? Did everybody here learn to ride a bike? Yeah, right? Learning to ride a bike is a procedural skill. Okay, it's a motor skill. If you're amnestic and you've never seen a bike, if we had patient HM who had his hippocampus resected and he'd never been on a bike, he could learn to ride the bike. And he'd be very skilled at riding the bike, except he wouldn't remember any of the time he spent actually riding the bike. He'd just be able to do it. So you can acquire skills that are these procedural, non-facts and knowledge skills, basically in the absence of this entire memory encoding system we've been talking about. And let's just show you the classic first paper on this. This is a paper that was done in Science in 1980 where they had true amnestic patients. Some were Korsakoff patients and some were CA1 hypoxic patients, and they had them learn a very difficult task, which is you have to learn how to draw an image that's been reversed in a mirror. So it takes a while to, the mirror's here and you got to go in the opposite direction to actually draw the shape correctly. And it takes a while. And what happens is over repeated days, the patient who's profoundly amnestic doesn't remember each day that they've ever been in the room doing this particular complex mirror drawing task. They get better and better and better and actually peak and get to the level that anybody in this room would get to. But they have no memory for the sessions. So this is an important distinguishing factor. And then you say, well, if you had to guess what areas of the brain might be involved in procedural learning and memory. How about someone want to tell me? I mean, you got to, from what we've learned in class, what are our big motor disorder cases? What? Basal ganglia. Exactly. So Parkinson's, Huntington's, etc. These patients will have problems learning new procedural skills. Exactly. The other thing that they also they lose is this thing called priming, and probably some of you have been, subjected to RPP and priming experiments or, whatever. By the way, the RPP should be done, right? I think I got some notice. Is it over? I got some, what? Oh, the first half is over. Okay. Remember, we're doing appetitive RPP, not adversive RPP. So no points will be removed if you don't do it. That's up to you. If you do it, you will get some credit. RPP recommends that 10% of your grade be dependent on RPP. I don't get it. It doesn't seem fair. It seems like indentured servitude, but that's just me. Anyway, so if you learn this list of words, right, if I give you this list of words and you have to learn them, and then you're a true amnestic person, you're going to, number one, not remember the list at all. But someone with a basal ganglia problem, if I give this cue on one of the words, actually the regular explicit memory amnestic will fill in the blanks. Just like this guy, I gave him a cue and he ended up figuring out baseball. Whereas if you do it with a basal ganglia patient, like Parkinson's patients, they will lose this simple priming skill. So very simple skills that are not complex. Motor behaviors and priming are impaired. And again, as was pointed out by somebody up there in the room, thank you, by the way, is one of the common causes is Parkinson's disease. Again, there's our nice, darkly pigmented, because of the dopamine-containing neuron, substantia nigra. This is just a cut through the brainstem, and you can see the depigmented substantia nigra. And as we mentioned previously in the class, this particular observation by a pathologist, just looking at postmortem tissue, really started to clue all this fantastic research on the substantia nigra, leading to all the treatments we're going to have. If anybody's really, really interested in this, there's a talk tomorrow at 3:30 in Tolman Hall by Phil Starr, who's a fantastic neurosurgeon at UCSF, who runs their deep brain stimulation program. He's really, really very talented. It'll be 3:30 in, I think, the 5th floor in Tolman, and he'll be talking about treatment of Parkinson patients who failed medication. Remember, 85% do well on meds, some don't, or they eventually fail on meds, and then you can do the deep brain stimulation that we actually discussed earlier in the class. So this would be implicit memory problems in these particular patients. And then we also talked about Huntington's disease. You saw some movies of these unfortunate patients. Here's your normal caudate nucleus, which should be pushed in quite nicely. And here's a classic postmortem of a patient with Huntington's disease. And you can see instead of having the ventricle being pushed in, it's not pushed in because you've got almost no caudate left. You should have a big fat. That's all caudate. And this is degeneration of caudate with the resultant hyperkinetic movement disorder with chorea. But the same problem in implicit memory as the Parkinson patients, even though the motor manifestations are completely different. Just a little anatomy, since we've got this up here. There's a normal-sized mammillary body. And in fact, if you were doing research in this area with Korsakoff patients, you can actually use MRI to actually get a volumetric measure of the size of the mammillary body. The first paper doing this was actually done in the Berkeley Psych Department by a colleague of mine, Art Shimomura. So that's normal. Okay, so that's pretty much it for memory. I think you should have a good feel of the neural system that encodes memories and how it can go awry in disease. So I think what we should do is let me just stop here for a minute. And since you've got an exam coming up, and I know these are very important to everybody, is there any particular questions on the last part of the course that you want to ask me right now since I'm here? I'm going to have office hours tomorrow too, and I'm getting some emails from people. But if there's anything you want to ask now about anything, go for it. Or is anything? Nothing? Yes, ma'am. What?
Edema tumor and
Start over.
For the
vasogenic,
and then the cytotoxic
Yes.
edema tumor. Can you kind of explain the difference?
Again? Sure.
Yeah.
No, that's a good question because this is a common problem. The vasogenic edema simply means that there's been whatever the brain problem is, a tumor, a brain infection, or whatever, it's releasing a toxic material that's making your little capillaries not be tight, right? Instead, your capillaries shouldn't leak fluid. And the way that it does that, these endothelial cells wrap, let's say this is your capillary, right? There's a wrapping around your capillaries of endothelial cells. And in vasogenic edema, instead of these cells being tightly coupled to each other all around your tube, your blood vessel, their connection breaks down and they leak fluid. So you're actually leaking proteins and water out of your blood, your actual inside of your blood, your vascular system into the tissue in the brain. So there's swelling because of increased water from leaky. It's a leaky blood vessel problem, and you can fix a leaky blood vessel problem by simply administering corticosteroids. And you usually can get a really nice response within about 24 hours. You tighten up, the cells get instead of being, if you want to just think of two cells wrapped around a blood vessel, instead of being leaking, they're now connected. And you get resorption of the fluid, you get really good response. Cytotoxic edema is really a worse. Even though vasogenic in presentation can look pretty bad, you can fix it. Cytotoxic edema means that the nutrients in your blood supply, which the key ones being oxygen and glucose, are gone. And everything that blood supply takes care of begins to die. And what happens when cells die, and that includes capillary cells, that includes glial cells, that includes neural cells, what happens is the cells themselves swell and they get bigger, right? So this is a healthy cell. It's that big. If the cell begins to die, it loses its ability to control its membrane pump, and the cell swells up and gets bigger. So you have all these increased swollen cells producing, again, a big mass effect in the brain. The only way to treat that is to stop the offending agent. But in reality, by the time they've got severe cytotoxic edema, probably the cells are not salvageable. Now, we've had some change just in the last few years, actually in the last few months, in terms of the criteria. It used to be that we would only treat an acute stroke if we really knew the onset of the stroke, and we gave them a clot-busting drug within 3 hours, maybe 4 hours. It's now with some very new MR imaging techniques, it looks like there's what's called an ischemic penumbra. There's an area that's going to die in the center of the stroke, and there's a large area around it that you can determine on MRI scan that may be salvageable all the way up to 16 hours. So what we do now, actually, and we do this in Alta Bates and all the hospitals, you have invasive interventional, interventional either radiologists or neurologists who typically what you would do is you just give a clot-busting drug. Then it became clear that you could actually put a catheter up into the artery and grab the clot in some people and pull it out. And now a study literally just came out maybe a month ago showing that the best Long-term prognosis is to give the clot-busting drug if it's before 3 to 4 hours, and in parallel, put a catheter in and pull out the clot, right? But if it's more than 4 hours and your MRI says there's salvageable areas, you can still go in. You don't give the clot-busting drug because you're still at risk for bleeding, but you can go in and put with a catheter and pull out the clot. Okay, does that, right? Okay, yes? What's the age of onset of seizures? Okay, that's another really good question. There was if you go back into the epilepsy talks, it really depends on the cause of the seizures. If you have a perinatal malformation, a genetic malformation, that kid may be seizing right as a neonate, or they may start when they're 3 or 4 or 5 or 6 months old. So that would be usually a brain malformation, something genetically abnormal. If you're going to have petit mal absence seizures, which I just had 2 of them. These little 3 per second spike wave seizures that kids have, that usually starts between the ages of, let's say, 3, 4, 5, 6, up until maybe 10 or 12 or 13. If you look at just onset of seizures in this age group here, probably if it's new onset, the single biggest cause is you probably had a traumatic brain injury and you've had a contusion that damaged just a little piece of your cortex, making it irritable. And the later you are, if you onset with the seizures when you're, let's say, in your 50s or 60s or 70s, your first thing you're going to think of is it post-stroke. In fact, Thursday, one of the patients I saw, one patient had this, I told you, Korsakoff's, but another patient was a left-hander who had a right hemisphere stroke and actually had reversed hemisphere organization, was aphasic with left-sided weakness, and also had left-sided spatial neglect, which we'll talk about later in the course, and he developed a seizure disorder. He just had started seizing. So about 20% of people with cortical strokes end up with a post-stroke seizure disorder. So really, it depends. Right now, with that said, you could have a stroke when you're 6 years old because you have a heart valve problem, right? And that could be so. They're not absolute, but it really depends. On the age of onset depends usually on what the pathology is. Yes. Okay. So the question: what's the difference between structural and metabolic damage in coma? This is good. This is another very critical clinical point. A structural cause of coma means that something is really physically suppressing your reticular activating system. And since you asked, here's where your reticular activating system is, right here. Okay, it's this structure of cells right around in the middle of your pons and midbrain that get activated and alert your cortex. So a structural cause of coma would be something that somehow is impinging on this. It could be pressure from a tumor. It could be a stroke. The area is actually physically damaged, right? And then you want to know what the cause of it is because it might be surgical. It could be a cerebellar hematoma, and the treatment is get them to the operating room and take out the hematoma. A metabolic cause of coma means that it's not so much that your reticular activating system is suppressed. Your entire cortex that allows you to be awake is suppressed. So a simple cause of a metabolic coma is you've overdosed on barbiturates, right? Your brainstem is still intact. There's no structural damage, but your entire cortex is suppressed. Another cause of, metabolic cause of coma, anybody who's had surgery, you've had a metabolic cause of coma, right? The doctor put a needle in and gave you something that basically suppressed your brain. Another metabolic cause of coma could be you have a homeostatic problem. So you went to Burning Man, you lost a lot of salt, and it happens. It really does. You lost a lot of salt, and your sodium drops to 122 or 123, and you're out of it. Basically, you're lethargic or comatose. Or you're in end stage. Just talking to one of my friends, he's back in the hospital with his mother in an ICU in Boston, and she's in renal failure, and she's out of it, and she's got, you guys in the back, she's got a problem because she's fluid. She's also got a BUN that's 10 times higher than her creatinine, which means she's dehydrated. I'm talking to the doctors in the back. And I said, well, maybe she needs to be hydrated, right? But it turns out she's also in congestive heart failure, so they can't hydrate her. These are. So anyway, that's a metabolic cause. The structural activating system of your brain, the reticular activating system, is intact. Your receiving part of this activating system, your cortex, is affected. Now, usually almost all metabolic comas you can reverse if you get at the cause and treat it. You fix the sodium, you dialyze the patient, et cetera, et cetera. Okay? Other questions? Yes, please. No, you don't. I just wanted you to see what a real practicing epileptologist does. So that was more for fun for you guys. You don't need to know the details. Yes? The Glasgow Coma Scale is just a way to rate somebody in the emergency room. And the number goes basically from 3 to 15. 15 means you're awake, alert, you can localize pain, you can talk. And the lower you get, the more problems you have. So usually if you're when you're around an 11, you're kind of woozy, and when you're around an 8, you're getting pretty deep into a coma. When you're a 3, you're technically brain dead. All your brainstem reflexes are gone. So that would be a 3. Someone comes in with a car accident and their Glasgow's 3, it means they're deeply comatose, they don't respond to pain, they have no brainstem anything, right? Their pupils are fixed and dilated, and their eye movements don't work. That's a 3. And if you get them into the operating room immediately, I've seen people pull out even with a 3, but usually it's a bad sign. So that's the range. It's very standard, a very standard scale that checks eye movements, response to pain, level of awareness, a level of consciousness, etc. Yes? What? Who have auditory? I'm sorry. No, they're gone. They don't respond to pain. Yeah, no, they have nothing. They're basically disconnected. So that's the Glasgow, 3 to 15. It's used in every emergency room. Okay, good. So again, you'll get your notifications on room assignments today or tonight. No big deal. Have a good time on the exam. Have a good time on the spring break. Wear a helmet. Don't let anybody slip you a roofie if you're in a bar. Make sure your booze is watched by your friend if you go to the bathroom. That's my health tip of the week. It's true. Happens. Yeah. Yes, sir.
What is the scan?
It's a MRI scan with an infiltrating tumor.
But how come it doesn't look like a T1 or T2?
It is a T2. It's just a little bit out of focus.
Oh,
it's
okay.
T2. That's a T1.
Oh, okay.
Okay?
Thank you.
Sure. They're all, there's no dumb questions. This is the stupidest thing I've ever heard in my entire life.